Welcome to the Turd Nerds. We are the functional gastroenterology podcast discussing all things poop. Before we take the plunge into today's episode, let us tell you a bit about ourselves. I'm Dr. Rebecca Sand, a naturopathic physician and acupuncturist, and I specialize in all things gastroenterology, hormones, and fertility.
I'm Dr. Ami Kapadia, and I'm a medical doctor trained in family medicine and functional medicine with a special interest in gastrointestinal health, food and environmental allergies, and autoimmune disease.
And I'm Dr. Ilana Gurevich, a naturopathic physician and acupuncturist who is board certified in naturopathic gastroenterology. I specialize in inflammatory bowel disease, IBS, and other functional digestive disorders. Let's jump into today's episode.
The following discussion is for educational purposes only and not intended to diagnose or treat any diseases or conditions. Please consult your doctor before incorporating any of this information into your care. The information presented on this podcast is not medical advice.
Welcome, everyone, back to the next Turd Nerds episode. We have a very exciting case today that Dr. Gurevich is going to present on chronic vaginitis as it relates to gut dysbiosis and the vaginal microbiome from a Turd Nerds lens.
Before we get started, I just want to let everybody know the Turd Nerds, we're kind of on top of it. We pre-record all of our episodes. We have them locked and loaded. We are like committed to this podcast. And something went terribly wrong where the three of us could not manage our schedules. Dr. Sand ended up getting a cold.
Imagine that, yeah.
This episode almost did not launch, but because of our commitment to maintaining great bowel movements for the universe and helping other doctors learn that, we made it happen. For the first time ever, we are not sitting in a closet.
We'll see how it goes
at home.
I feel like we've graduated in our technology or something to make this happen.
We will see. I'm sure we will get feedback one way or the other. If it's
we don't get the pre-podcast gossip session when we're virtual, though. I guess we could add it in.
Yeah, I kind of miss having you guys right here, my turds, but we're
okay.
here.
So let's dig into my case. And what I want to say is I'm going to present this particular case. And this is another one like we got some pretty good feedback about our nausea case. People seem to like that format. This is also a case that's still in session. It's just really, this is a conglomeration of patient that I think we're all seeing that have both GI issues and female vulvovaginal issues. So this is a woman in her middle 30s, and she came in with her two chief complaints was terrible intractable bloating that was like tending towards constipation. So 5 to 6 bowel movements a week, either a Bristol 1 or a Bristol 4 on the stool chart, really bad bloating that would be there all day long. And then her other thing was chronic BV and chronic yeast. So she would get either a bacterial vaginosis infection or a yeast infection. She'd treat one, she'd get the other. She'd treat one, she'd get the other. It would constantly flip-flop. And because of that, she was obviously having a lot of dyspareunia. She was having bleeding after intercourse. All of a sudden, and this was like, all of these symptoms kind of started just like all at once, and she has no idea why it was triggered. She does have a childhood history of atopy, so she has some eczema in childhood. But
it wasn't like a new partner she got.
No, she's been married for like a decade.
Okay.
It was not a new partner.
When you said she was flip-flopping between the BV and the yeast, was that being treated conventionally?
She was exclusively seeking conventional care before seeing me. And that's a really good point, Dr. Sand. That's an amazing point, because how do we treat either BV or yeast conventionally, vaginally?
Right. So, I mean, there's only a few options, and then you're kind of out of luck. And
what are those options?
Fluconazole, Metrogel, then you move on to the more
oral.
Right. And then there's a second line agent. I think there's another vaginal agent that you can graduate to if you're not getting anywhere with recurrent metronidazole orally or vaginally.
Metronidazole is one of those antibiotics that we use a lot, and I don't love it. I try to avoid it at all costs. The problem with metronidazole is it will wipe out a lot of the microbiome, and that will cause
it
GI
makes you
issues.
Feel terrible.
Right. So generally we always want to give the local treatment when you can, if you're going to use it. Right.
Yep.
I mean,
but I think by I think that means I don't think that means conventional medicine.
I think it switched some. I see more recommendations for treating locally. Patients don't always want to do local treatment. So then we'll, get a call back and we have to switch it to oral, and we try to, you can only, go back and forth so many times sometimes. So I think we don't always do a great job of explaining why we're choosing the local treatment. Maybe we do, but
The difference, yeah, I see it, gynecologists order local treatment, Zoom care and urgent cares order the pills.
And family medicine docs, I feel like will also at times, I see more people being offered oral metronidazole for first-line therapy than vaginal metronidazole.
I would say where
personally.
I've worked, I've seen more local treatment in the last several years for acute urgent care visits, at least offered. Again, the patient may not want to do that, and we may not always have the capacity to fully explain why we're choosing that treatment, because it's annoying for patients to do the local treatment. So
yeah, I mean, is it more annoying than doing the oral treatments?
I mean, some patients think it is, but again, I think if we explained the stakes,
right.
Totally.
Yeah,
I don't think it's that hard.
Yeah.
I mean, I would just rather keep, I think there is actually this growing awareness now in the general population about the microbiome and how we're overusing antibiotics. But I also think if your doctor says, take this and it'll help, you're not thinking this is going to start my cascade to, vulvovaginal issues for the next decade of my life. You're like, oh, one and done. And unfortunately, it is not generally a one and done protocol.
Agree.
So the other thing that was really interesting to me about her bloating is her bloating would just start out of nowhere, right? So sometimes it was triggered by water, sometimes it was triggered by food, it was sometimes in the middle of the day, it was sometimes in the morning, it was sometimes in the afternoon. It wasn't like this typical bloating that you assume that's really just, GI or dysbiosis motivated, where you might wake up flat in the morning and then you get improvement during the day. Her bloating would, sometimes she'd wake with it, sometimes it would get worse around water. What does that make you guys think?
Wait, Alana, first did you mean to say it's not bad in the morning, then it gets worse throughout the day? Is that what you said? Like that's the typical.
So that's a typical, when I think about dysbiosis, I think of that bloating that is, you wake up flat because you haven't been eating for like 12 hours or 8 hours. And then as you put food in your system, you get progressively more bloat. Okay. That type of bloating for me is like a dysbiosis bloating, fungal overgrowth, bacterial overgrowth, maybe some parasites, but it's not that. So, but it's not the one that bloating that presents where sometimes people will drink water and bloat, or some people bloating. Whenever I hear that, what I think is mast cell activation.
Right. Histamine, allergy, mast cell stuff.
Yep.
Totally. It's a really good intake question.
Yep. And that was what her bloating was like. And so what we did with her is after the first visit, I took my comprehensive intake, and then I was like, well, it does sound like you've got mast cell activation. And, we have a bunch of episodes on mast cell activation if people want to go listen to those. But I started her on an oral cromolyn, because cromolyn sodium is a topical agent that stabilizes the mast cells orally. And then I also ran that candida immune complex and that candida panel that Dr. Kapadia talks about on our first 3 episodes. We're treating small intestinal fungal overgrowth. Dr. Kapadia gave us a huge rundown. So I ran on her that candida panel, the candida IgA, IgM, and IgG. And then I also ran a candida immune complex. That's where we started with her. So then she came back, and her labs were really interesting. So, and I see this a lot. I'm curious to see if you guys also see this a lot. So we have 2 options of running these tests, either through conventional labs or there's some functional labs. The conventional labs, the candida IgA, IgM, and IgG will come back very quickly, within 24 hours. And those were all negative. And then the candida immune complex will take weeks, like 2 to 3 weeks to come back. And that came back at a 4.35, which is very high. So ranges for candida immune complex is anywhere over 0.9 is positive. The highest, I have seen one patient come back at a 5.5, and I have a small handful of patients that come back at a 4. What are you guys seeing with that?
Yeah, like the 3 to 4 range is kind of the highest I've seen. I don't know that I've ever seen a 5. And if you do the functional test, it's like a totally different range from what I'm remembering. So you just have to, that's what Dr. Gurevich is talking about, is the conventional lab testing result.
The functional lab is in the hundreds, but I think their cutoff is under 100. I think under 100 is considered normal, and anything over 100 is considered positive. And so she came back at a 4.35. That was a very elevated result. And so I was like, great, I can explain. Now, remember, we think, and Dr. Sam, maybe you can actually update us on what we actually think these days. I was under the impression that we were assuming that the vaginal mucosa comes from the GI.
You mean the microbiome?
Sorry, the vaginal microbiome comes from the GI.
I mean, it's safe to say there's an interplay that's significant, and from the urobiome, right, as well, whatever's going on in our urinary tract, which is why we have to treat both. Is that what you're asking?
Yeah.
I feel like I sort of think of it like the sinus microbiome where it's related, but I feel like it also often needs separate treatment and may not resolve when the gut issue resolves, interestingly.
Mm-hmm.
So it's like separate, but associated, like Dr. Sand said.
Yeah. And also, depending on the treatment interventions that we choose, it may or may not, like our treatment interventions might be really GI specific and not getting to the vaginal microbiome. And so we might need to layer in vaginal microbiome treatments.
Yeah. And for the candida testing, and I know we've talked about it on this podcast before, it's not specifically telling us where the candida is. So, even though this person has candidal vaginitis or, potentially intestinal, it's not specifically saying one thing or the other, right?
I mean, there was one study that I could not find the original paper that lab had referenced, and it was the elevated immune complex was in relation to intestinal overgrowth.
Oh.
So if you look at Quest, if you go online and look at Quest portal, they will actually cite that study that Dr. Kapadia is talking about, going back to, I think, 1952.
Maybe, or 60, it was a long time ago.
That says that candida immune complex in particular is in correlation with intestinal candidiasis.
Cool. So cool.
I mean, I'll be honest, I haven't done a lit search since. I am using this.
I did. I mean, before I did all of those, and up to the last few years, that was still the only one with that test that
what would be helpful to know is the correlation between intestinal and vaginal candidiasis.
I agree. Everybody's nodding their head yes.
Yeah, someone study that and tell us. Link the paper to us when you publish it.
Yeah, I feel like, and this isn't based on literature per se, although maybe it is and I just don't know, but I feel like I've seen patients with recurrent vaginal issues and recurrent sinus issues where the gut wasn't involved, but I haven't seen, I think if the vice versa, when the gut is involved, often there's interplay in those other organ systems, if that makes sense.
I would totally agree. I would totally agree. Yeah. So we sent her home with cromolyn. We sent her home with this immune complex test. She came back and we did not get anywhere with her bloating. Her bloating was still somewhere from a 4 to 10 out of 10. Her bowel movements, interestingly, improved, but she didn't get anywhere with her bloating. So my question of, you bloat with water. If they tell me, without me asking, if they tell me you bloat with water, I'm going to think mast cell. And so my thinking was not in line for her, did not track at all. And so we discontinued the cromolyn because it didn't work. She went to go see her gynecologist, and her gynecologist started her on yet another round of protocol. After the protocol, they re-swabbed her, and she was negative for Trich, Candida, and BV, but she was like, I am still super symptomatic. And then her skin was actually doing pretty well. So at that point, I started her on my antifungal oral protocol. And despite and I also started her on my vaginal protocol for the chronic vaginitis. So, the oral protocol that I used was the one I usually use. I was using nystatin, and I was kind of a little bit torn to use nystatin because of the fact that I was torn to use nystatin because she was having vulvovaginal candidiasis, and we know nystatin's never going to get there. And so this whole the reason why we're doing this episode, this whole conversation started when me and Dr. Kapadia were in a car together, and we were talking about this, and Dr. Kapadia was like, sometimes we'll use vaginal nystatin, which I had never
it's
used.
not available anymore, but it used to be used, I believe, as more of a local treatment, because the oral isn't going to get there. So you can get it compounded, or we can do one of the many other things that we do now.
Yeah. So I started her on a nystatin protocol using hemicellulose, which I
This
always
is our
use.
typical car conversation when we're
Yeah.
doing fun hikes and such.
I
Sorry,
do
go
feel like
ahead.
we need another group. We need more hobbies. Like
Right.
if we're in a car together, walking
You
in
did
nature, but
say
still talking about work,
you did say your hobby is naturopathic
that
gastroenterology.
I have and cooking. That's where I land.
Okay. All right. Well, you got something.
Um,
Sorry, go ahead. You do your typical
so
biofilm protocol.
my biofilm protocol specialize on fungal treatment. I do nystatin, I do my antifungal parade. And then I started her on, a pretty she's got this really protracted vulvovaginal issue since 2020. She hasn't been able to get it stabilized. So I'm also doing a vaginal protocol for her using some of our topical agents like boric acid, like on pulsing vitamin C, that vulvovaginally and probiotics. And so we were trying to do that. And so what I do, ever since Dr. Kapadia told me about the Candida immune complex, my protocol now is I'll run it, and then I'll do my treatment protocol for 3 months, especially if it's nystatin, because nystatin is slow to work. And then I'll circle back around and I'll rerun in 3 months to see what that immune complex is coming back. What are you guys doing with the lab tests?
Yeah, I mean, I used to always use it as more of a baseline and then follow clinically. But since you told me that, I think there's quite a bit of utility in rerunning it because our patients are so complicated and multi-symptomatic that I think it's nice to get some follow-up data. So I think it is a good idea to rerun it every couple months because sometimes it just takes so long, but you're making some progress and it might be hard to tell symptomatically, you know?
Yeah, I did the exact same thing. I kind of used it as a baseline and then guided treatment because yeast is just very hard to pick up in general. But I'll also have symptoms kind of guide. Like if people are feeling better, great, go live your life. But if I'm not getting the kind of traction or symptoms are getting weird and I'm confused about what I'm actually treating, I think it's a great way to just assess what's on the table.
Yeah, kind of like how you all had taught to use the SIBO testing and the reason to retest, because if they're still symptomatic and the numbers go down, you've taken care of this and there's something else going on. So
Yeah.
we don't have, unfortunately, that amount of data for any candida testing, but the immune complex is something.
Yeah.
Totally.
And I will say there's a couple of things. First, I never do a fungal panel anymore without giving them some kind of dietary guidance. And generally, I'm asking them to do a low carb diet. So, I really like the Whole30, even though there isn't a huge abundant amount of research on it. I think there's a lot of anecdotal, there's a lot of supports. So I think keto diet, if they can do that, keto diet probably has more research on it than any other diet we have out there. It's just, I felt terrible doing keto. I only lasted 8 days.
You mean, Dr. Gurevich, you're talking about when you treat them,
When I'm
correct?
treating, with treatment.
Okay.
Yeah, not like a provocation.
No. I do think it is important if we're going through this treatment process that they're not feeding the fungus, which is quite hungry. And also, the fungus is like, in my experience, it's what triggers a lot of like food addiction. Like you want the sugar,
Totally.
you want the alcohol.
Yep, totally. The
Yeah,
alcohol is just killer.
Yep.
Yeah, it's good to have substitutions for people. I don't like to require that type of diet longer term, but I think what you're saying is a good idea for a period of time. And the things you're describing are not overly restrictive. And, I tell people when you're eating out and such, don't worry too much, but do your best.
Yeah.
That, like we've talked about many times, but there's so many more options for people these days than what we had like 20 years ago to actually get like unsweetened almond milk, which you couldn't
Right.
even get like 20 years
Right.
ago,
Yeah, I think the Whole30 is so great because there's so many resources. Like it's really easy to find recipes and follow, and it's clear cut, which is great for
Right.
people's brains. For people where like I'm hesitant to give diets or that's just really hard for them, I'll do similar to what you were saying. I mean, like, don't be so strict that your quality of life is diminishing, knowing it's short term, like do the best you can. But if you are going to have like white rice or, things that are pretty sugary, try to pair it with fat and protein.
Yep.
To slow the uptake into the bloodstream and not feed that yeast as much as you can.
Yeah. Sorry, go ahead.
No, go on.
Oh, and for people, not every, just my practice I had so many patients with allergic issues for so long that a lot of the general population doesn't have food allergies. So they could just remove processed sugars
Totally.
and alcohol, and that could be like a great intervention with someone doing the whatever type of treatment modality you're doing for this, herbs or whatever.
And kombucha.
Right. For you have to be, because kombucha has sugar, so that's kind of off the table if we do a good job of educating them on like added sugars, which
Yeah.
So Dr. Stan, you remove kombucha.
Yeah.
you definitely remove kombucha.
Because the other thing that I'm doing is I'm trying to introduce fermented
foods.
Yeah, but it's got yeast in it.
Yes, totally. But it's got a different variety of yeast that's not candida.
It does. Yeah.
And we're working, I mean, the immune complex is that's the negative thing about this test is we're only looking at candida.
Right. And I don't have a problem with the fermented foods if they're not a super allergic person, but kombucha has a ton of sugar in it too, doesn't it?
I think it depends on how sweet the kombucha is.
Yeah.
Like when I used to do my own, it was like vinegar.
It's sort of like using probiotics as well. Like I don't want to do that while I'm trying to actively kill things in the small intestine. I'll introduce it later, but it's sort of like a balm for the gut. And most people don't feel so great on it anyway if they're reacting to yeast.
So I have the exact opposite view. Like literally,
I love this.
I am like, if I'm doing this whole thing where I'm trying to take down the predominant species that's infecting your microbiome, that's giving you a lot of pathology, I need to put stuff back in. And
at the same time, though?
At the same time.
Aren't you worrying about it decreasing efficacy on both sides if you're adding antimicrobials and bugs?
Well, I'm mainly focused on antifungals and
food-based.
Yeah.
So the way the realization that I had, I was giving a talk on biofilms. That's like I love that stuff, and I was doing all of this research about like when things change dietarily, and I realized that in the 1940s, two things happened at exactly the same time. One, we developed refrigeration, and two, we developed antibiotics, and we can very clearly track a line of poor health that stems from 1940s on. By 1950s, everybody in the West was getting antibiotics. Up until the 1950s or 1940s, there was not a single culture in the entire planet that did not use fermentation as their main way to preserve food. In the entire planet.
Right. I mean, I think the only issues we've talked about before doing like the 5-day yeast mold elimination challenge just to see if you're sensitive to those types of foods, and you can refer back to those initial episodes we did, especially because some of these people with MCAS allergy issues aren't gonna maybe not know they're reacting to those foods, but if they're not part of this allergic population of people, again, I think that you could stick with the minimal of processed sugars and alcohol, and if they are in that allergic group, you have to kind of sort of figure it out along the way, whichever way you want to do it, whether you remove them for 5 days and then have them try it and see if they tolerate those foods and they can include them, or if you just want to leave them out for a while. I mean, again, the average person doesn't love like kimchi and sauerkraut. So they may not be like, oh, I can't eat those, I'm not going to be able to do it,
Yeah. Okay, so the other thing that I will say, running these tests, I think it's been 2 years, right? I think you first told me about this 2 years ago. Running these tests every 3 months, I will tell you that the people that go into negative ranges are the people who stay on a low carb diet.
Okay.
I think the hemicellulose was something magical, and I think that the low carb diet is something magical when you're dealing with chronic yeast. And I really struggle, and I think probably all three of us are struggling, but I really am struggling with, orthorexia, which I think is so abundant, and I think that we as a profession feed into making it worse, and I struggle. So I struggle with that, and then I also struggle with the fact that the American diet, the Western diet, is just an unhealthy diet. You know what I mean?
Yeah.
And telling them that they don't have to food restrict is also crazy, because our food is now more chemistry than food.
I have a couple thoughts.
I'm ready.
Dr. Sand, did you want to say something first?
No, go for it.
Okay. One is, well, Alana, the Whole30 isn't really low carbohydrate. So
it's grain free.
Right. But I mean, they don't restrict sweet potatoes, regular potatoes, tubers, squashes. So it's not really low carb. It is grain free. So you're saying your patients that kind of stick with that type of a diet long term. So I don't know that I would call that low carb.
Well, it's way lower carb than the standard American diet.
Okay. It depends what our reference range is. So sure.
Yeah. That's true. That's fair.
The other thought I had is that, yeah, I think I had more of a problem with restricting people in that way when I thought we were doing it just for this. I was like, there's got to be another way we can manage their dysbiosis. But as you both know, I have experimented with a continuous glucose monitor, and we know that a lot of those same foods spike our glucose. All the protocols for dementia, preventing dementia, metabolic health are generally lower carbohydrate, what Dr. Bredesen calls keto flex. So in my mind, it's easier for me to accept that type of a eating program. And maybe we don't need to even call it like a diet, like just eating like that for our general health, because we're not farmers. And Dr. Gurevich and I, we were talking, like, I'm pretty sure the diet I was eating for many years was meant for like someone farming in Asia and not really for me. Because if you're doing that much physical activity, like, like you said, the glucose gets taken up quickly. It's not like sitting there feeding all kinds of things, probably contributing to all the things we're talking about. So I don't know. In my head, it's easier to frame it as that this is really just this is the eating program for all of us for sort of like general metabolic health. If we don't want to have cognitive decline, metabolic health decline, heart disease, it's not just because we can't figure out how to treat someone's gut imbalance,
Yeah, and also like the grains and carbs, especially in this country, are pretty messed up. Like it's
Right.
not just the carbs, it's everything that comes with it, and it's in everything. So I think removing the inflammation aspect of, what gets paired with those is worth a lot too.
Yeah.
I think we as a community are now significantly more aware of how our dietary recommendations can feed into this orthorexia phenomenon that patients are
Right.
struggling with.
Mhm.
And I also feel like there needs to be an awareness about how unhealthy our
Mhm.
food is. Like, my business partner has a young child, and I was like, how is your wife not petrified of the food industry? I can't think of anything that scares me more than the food industry.
Yeah,
Yeah.
when I'm working with patients, especially like when we're first establishing together, I tell them from the get-go, the number one most important thing is your relationship with food. If you ever feel like that is getting compromised in our care, we have to stop and address that first. That is going to trump treating the yeast, treating whatever, because I don't want to lean people into, disordered eating patterns. That quite literally kills people. Like that robs
Right.
you of your life and kills you. We cannot mess around with that. So I do regular check-ins with my patients if I am messing with their diet for various things, just to make sure we're keeping it safe, because like totally our profession contributes to that.
Yep. Yep, I agree. Okay, so this patient, I started her on a vaginal protocol. I started her on a oral yeast protocol. And then we reran, it was about 3 or 4 months, we reran that immune complex, and it dropped in half. So she went from the 4s to the 2s.
Cool.
And simultaneously, she was doing some work with her GYN on the vulvovaginal stuff, and that changed also. And so, I was in touch with her GYN. It's kind of my favorite GYN to refer to. And we had a conversation about switching her. The nystatin was working, and I could have easily kept her on the nystatin, but the GYN wanted to start her on diflucan for the vulvovaginal stuff. So I was like, well, why don't we switch to a diflucan protocol? And, we'll go fluconazole. Where we ended is we're going to go fluconazole. We're going to let that roll for a couple of months. And then we're going to rerun the immune complex to see where she is.
Sorry,
Overall,
did you say how you dose the fluconazole there? Was it the
no,
once weekly?
no. So what I do with my fluconazole dosing, and I mean, I'm going to be honest, I don't know who told me about it. I just kind of came up with it. Generally speaking, I go 150 milligrams once a day for 5 days. And then I
Yep.
go 3 times a week for the next 6 weeks. I
Yep.
used to go twice a week, but then I had this patient, this inflammatory bowel disease patient, who, there's this correlation. I think Dr. Kapadia talks about it, this correlation with IBD and fungal overgrowth. So I went fungal, I went she was dosing herself. She was a physician. She was dosing herself at 3 times a week. And so we completely got her IBD into remission. Like total, we were running Crohn's monitor scores. They were like in the 40s. I couldn't break the 40s. We did a fungal protocol. She dropped down to the 20s or under. And so then I started dosing diflucan 3 times a week for 6 weeks, take a couple of weeks off, retest. You always have to park through the patient about the LFT functions getting elevated and just all the risks, because diflucan is a stronger drug than nystatin with more potential
Totally.
risks.
And no alcohol. You cannot
Yeah.
consume alcohol at all while taking that.
Do you guys, so that's where I left off with her. Do you guys have other thoughts about what else I should do?
Well, where was she symptomatically with that? Or you still haven't seen her yet for?
Well, no, I just saw her when she dropped in half. We were actually getting somewhere. So the only time, this brings us back to our fermented food conversation. The only time she was having symptoms is when she was eating too much fermented foods.
Okay, well, there you go. She's a
Wow.
reactor
So
Did
to those.
you, I forget, did you say you tested for mycoplasma, ureaplasma?
no, I did not, but I'm pretty sure her GYN did. Can I also just do a quick little side note on mycoplasma and ureaplasma?
Please.
Yes.
I have somebody that I've known for a long time. She used to live in Portland and she moved to Boston and she was having all this dysuria symptoms. And I was talking to her and I was like, oh, somebody needs to test you for ureaplasma and mycoplasma. She went to her GYN in Boston, like in UMass, like one of the biggest medical industries. And they were like, urea, what? Myco, what?
Hmm.
They ran the swab and it came up back positive. And they were literally like, we do not know how to treat this.
Did
Like,
okay, I mean,
I,
up to date gives some information on, was it for urinary symptoms or, okay. That's
yeah.
a little bit less known, I feel. I don't know that I would have known to run those for urinary, like
Oh,
as a separate swab. I mean, I ran it on patients with chronic vaginitis, but I don't know that I would necessarily have thought of that for when there's recalcitrant urinary symptoms. I've run that sort of more involved PCR test, but I don't know that I've ran that swab that you're describing.
it's so interesting because the way I learned about it is I was seeing these patients that were having dysuria and they were running UAs and the UAs were coming back negative. And then we started
Right.
running the urea plasma and they were coming back positive. And that was like, I only knew it. I mean, I knew there was a vaginal component, but I generally only knew it for the dysuria.
Hmm.
Um,
Interesting.
so that's where I am with this patient. Anything else that I should be thinking about?
Are you doing like any vaginal probiotics?
Yeah, we're doing, and actually what happened with the GYN is the GYN was basically like, hey, can we take a, because she was starting to get a lot of like just pain, vaginal pain. And
Yeah,
the GYN was like, hey, can we stop putting things in your vagina for a little bit?
totally. Yeah, I also, I'm partial to like body work, but pelvic floor PT or abdominal therapy or visceral, specifically to get better circulation to that part of the body,
Yeah.
or pelvic movement in general, because again, people are so stagnant there, can help with healing, like immune function in that area.
Yeah, totally.
And
Yeah, and I
did
mean, oh,
did symptoms flare with cycling, like with her period?
Yes, she had terrible periods. She had terrible PMS. Everything would kind of get worse around her menses. But you know what helped that is calcium D-glucarate.
Totally. Totally. Yeah. And then are you dosing that just in that window or throughout the month?
I give people the option, but I think it's
Yeah.
easier to dose it just the minute you get symptomatic, but then you kind of have to be symptomatic for a little bit to realize you're symptomatic.
I know. Yeah, I tell people to if they are regular to kind of front load it by a couple days if they can
Yeah,
just to get those estrogens and beta
yeah.
glucuronidase regulated. What if, I mean, when you can, assuming she's not better, when you can do things vaginally, again, the boric acid prior to menses
Yes, that's
or
it.
with menses,
I was doing that protocol and then vitamin C post. And I'm
totally.
just wondering if the microbiome has changed because we cut her immune complex in half. Oh, that's
Mm,
the other thing that I do want to say about immune complexes is it's not I often do not see it just be a down trajectory. Like there is definitely some bouncing up and down that happens.
yep.
I will say generally speaking when I get somebody negative, they stay negative. But there's like a flow in that. And that's usually when I'm starting to see it bounce around a lot, that's when I'm kind of thinking, okay, we should increase treatment.
Yeah,
yeah.
I often tell patients that yeast fights back.
Yeah, that's a
Like
good one.
SIBO, it's a in my opinion, it's a pretty general. If we're only dealing with SIBO, it just goes down. Like we can predict that, we know how to treat that. Yeast, sometimes we have to change treatments. We have to learn what it responds to, and I personally see more die off with yeast.
Hmm.
So that's what I tell my patients. We have to wait for it to fight back.
And if she has benefit or partial benefit, but then it keeps kind of returning, there is literature on allergy and recurrent vaginitis, like environmental allergy. So it's just another avenue because I had so many patients with allergic issues. where that can potentially help, whether it's to environmental allergies or candida allergy.
Okay.
Cool.
Or contact allergy, even for that type of an issue.
That's, yeah.
You can do like cromolyn douches, right?
You can.
Remember,
Cool.
she didn't
Or
have any
Benadryl.
response to cromolyn orally.
Or,
Yeah.
right. So maybe
Yep,
a different, right.
Yeah. But yes, I mean, I never knew you can put it vaginally, actually.
It's just a topical treatment. You can put it any mucous membrane. It's wild. It's
Yeah, because
so cool.
nasochrome is cromolyn. Yeah, that's
Eye
true.
drops. Yeah. Yeah.
Okay.
Right.
Cool stuff.
All right.
Great
Great
case.
case, Dr. Gurevich. We'll have to do a follow-up continuation once we get more data.
Yeah. You know, I love anything microbiome. Here for it.
Should we do a recap?
Sure. What I learned today is there is a connection that no one knew between the microbiome, all the great bugs in different parts of our body. Yeast is worth thinking about, worth testing, and the blood testing can offer clinical benefit for people, not only to diagnose, but to be able to track, correlating with symptoms and whatnot. And always have the GI microbiome on your radar if people have recurrent vaginal symptoms.
Right. And they may need separate local treatment. Sometimes we can overdo that, but that's often at least a piece of the puzzle and not just treating the GI.
Yep.
Okay. Thanks, Turd Nerds. Thanks for tuning in.
Awesome.
Bye.
Thanks.
Bye.
Thanks for joining us today. Stay tuned. We release episodes every 2 weeks.
If you like this episode, please subscribe and don't forget to rate and review us to help spread the Turd Nerd word.